Well, I thank IPS for letting me in.
Thank you, sir.
Topic, and I can't
appreciate discussions because we knew that you're going to initiate a lot of discussions today.
Yes,
I can't miss Dr. Imhoff and face to face with him.
You can open your camera, sir.
we can't see you.
We can't see you. I think your camera. Yeah.
Is it fine?
Perfect.
Good.
Good, sir.
Okay, we are live, sir.
Well, I thank IPS for letting me in.
Thank you, sir.
Topic, and I can't
Appreciate discussions because I think there
We
is
are
a
live,
YouTube
sir.
live
Someone
somewhere.
has opened a YouTube, please. Yeah,
Yeah.
yeah,
We are
please.
live, sir.
Okay, perfect. Thank you, Pradeep. Welcome Indian Arthroscopy Society members today to our webinar on acromioclavicular joint instabilities. Professor Andreas Imhoff is a popular name in India, and we were just remembering him when he was last time with us during annual conference of Indian Arthroscopy Society in 2014 in Hyderabad, and we all appreciated his shoulder rotator cuff surgery. And he is back with us today, virtually though, on a very important and a difficult topic today, discussing about acromioclavicular joint instabilities. Shreyash Gajjar, our friend from Mumbai, has been kind enough to coordinate and help Dr. Andreas be on virtual platform today with us. And Shreyash, if you can briefly introduce the topic and credentials of Professor, and then we can have his talk. Thank you.
Okay. Thank you very much, Dr. IPS Oberoi, and hello, everyone. I welcome you to this webinar on AC joint injury. Where are we today? The acromioclavicular joint serves as a link between the shoulder, girdle, and the axial skeleton. Whilst low-grade injuries heal with non-operative treatment, the management of high-grade injuries has not resulted in good outcomes. To date, a myriad of surgical techniques have been proposed to address unstable AC joint dislocations, which are indicative of the uncertainty that exists in the optimal management of these injuries. And to share his experience and expertise, we have a well-renowned surgeon, Professor Andreas Imhoff from Munich, Germany, who has done extensive work on this topic. He is the professor of orthopedic surgery, the director of the Department of Orthopedic Sports Medicine, Technique University of Munich, and the hospital Rietz the Isar. He completed his medical degree at the University of Basel, where he also received his PhD in 1980. Subsequently, he held positions as a doctor and scientist, which led him to the universities of Basel, Zurich, and Pittsburgh, USA, to pursue sports orthopedics. In 1996, he was appointed as successor to Professor W. Burnett at the TUM University. He's held several key positions in the German Society of Arthroscopic Surgery, German Society of Orthopedics and Traumatology, the ISACOS, ESCA, AOSSM, AOA, SESEC, SICOT, and many more. He has received numerous awards and honorary and corresponding memberships of various societies. He's also been editor of the Journal of Arthroscopy, Operative Orthopedics and Traumatology, Journal of Shoulder and Elbow Surgery, and the ESCA Journal, to name a few. He's also had several publications, including contribution to book chapters, and is regularly invited as faculty at international and national meetings. So really, the Indian Arthroscopic Society is honored and really grateful for Professor Andreas Imhoff to accept this invitation. And I would like to invite him to please give his talk on AC joint injury. Where are we today? Prof, please share your presentation. Thank you.
Yeah, thank you very much for this wonderful introduction. I'm really honored to be with you this evening. To be honest, I rather would like to be really live with you, in-person meeting. But anyway, maybe next year it will be possible. So now we just will start with my presentation. I try to upload it, and I hope you can see it. Yes, now you can see what you already mentioned about my publications in the last several years. That's the newest publication. Yeah, just books about advanced shoulder arthroscopy. It's even not only in English, it's also in Chinese now, an edition. We have other books about rehabilitation. instability together with the ISOCOS Shoulder Committee, where I have been the chair for 4 years. But now we want to go a little bit more in detail. AC joint injury, where are we today? I will give you some biomechanical background. I will show you the ISOCOS classification, some arthroscopic experience I have since I started in 2003 when I did the first arthroscopic procedure. And then finally, I will show you new arthroscopic solution when we have an AC joint injury. Here's just a picture of Munich, and in the back you will see the mountains. That's the Alps between Germany and Austria. So this is the look when you are coming to Munich, flying into the town. You will see old houses, churches, and also some part of the mountains. These are my disclosure. Royalties, consultant, research support, and also I'm working on editorial boards. That's just the first case. 23-year-old female sports science student. She had a Rockwood 3 dislocation while she was snowboarding, and you see on the 2 X-ray, you see the gap here on the AP view, but it's more or less here in the horizontal plane where you can see here the lateral clavicle and the acromion. So the clavicle is going back and forth. It's not type 4 because it's more instable. It's a little bit of instability, but it's not so clear. So in this case, we did, or somebody did a reconstruction of the 2 ligaments between clavicle and coracoid with 2 tight rod system. It was not in my hospital, but it doesn't look bad. But when you look closer, maybe there's something not so perfect. So that's 6 weeks later. You already can see that something happened here. It's not on the same position now anymore. Here on this X-ray, through the scapula, we see now it's going up a little bit. So it's not really perfect. And this is now 3 months later. And what you can see now, she had a trauma now. Now it's clearly type 4. We have a dislocation both direction, but still we have the blades on the clavicle on the coracoid. So something happened. Maybe the tape is broken or the bone is broken. We will see it later. Now we do a CT scan. So the clavicle tunnel are maybe okay. You can see the 2 tunnels. They are not so bad, maybe a little bit too much in front. But here, what happened here on the coracoid, now you can see that the bony pieces and the 2 tunnels are convergent. They're going in the same tunnel, and the plate here is inside of the tunnel, so that cannot be stable. Then they are fluctuating. So what shall we do next? Now it's recurrent, it's chronic. What shall we do next? Yeah, we will see at the end of my talk. I will show you some solution. So it's really most important is that we find the correct diagnosis, and the imaging conditions are sometimes quite difficult. We just published a new review how you can really do the imaging modalities. How should be used for accurate diagnosis. It's a systematic review in the BMC. It's an open access publication. You can easily pull it down. Actually, there is no consensus on a gold standard for a diagnostic, but the reliability for diagnostic vertical instability using bilateral projection show a high level of reproducibility. So the horizontal instability is the most important part, and it's most inconsistent. We had 1,000 publications and went down, and that's what we could find. So finding the correct diagnostic, that's easy in this case. 20-year-old, Rockwood 5, male, that's very easy. Everybody can see it, Rockwood 5, that's easy. But in this case, it's not so easy. You see, it's a little bit higher here. Is it a type 2? Or is it more? it's now holding something. You see the difference here between so the distance between the clavicle coracoid is almost the same. It's just a little bit. Is it really an instability or not? So that's a type 4. You need a second view. You should go to the lateral side. You should do an Alexander view or the Basmanian view to see it in a second direction. Otherwise, you will miss it. So in 2002, I started with my first arthroscopic procedure with the AC joint. You see the scope here. So the additional portal from the side for preparation. And here when we use the first anchor for fixation. So that's now 2002. The first publication we started with 2 titanium anchors in the coracoid, 2 plates here. I thought at that time we should do something anatomic. Most anatomic, there are 2 ligaments. And Banjai Chandrit from Thailand, he was working with me and he did the biomechanical background. And then from this anchor, we used then corkscrew, bigger sutures, just pulling through the clavicle here with a key wire, pulling the sutures through the clavicle and trying to fix it. So we wanted to have something minimal invasive. The properties should be similar biomechanically, a single step procedure. So we had some guides, as you can see, that's just the first prototype, and they should be all arthroscopic. By mechanical testing, we tested several anchors here in a simple machine. You see how we did it here. And interesting, the red bar here is the native ligament. The native ligament have 578 Newton. Corkscrew is fiber wire number 5, that's 760 Newton. And the Weaver Dunn had only 112 Newton. So Weaver Dunn is far below, is never stable enough. You cannot use it for reconstruction. Otherwise, or you combine it with something else. Again, here's the stiffness and the elongation. The red is still the CC ligament. You can see, so we need something stiffer here. The Boswell screw, this one here. The elongation, that's a PDS suture. It's not used, you shouldn't use it because the elongation is too big. So it should be somewhere corkscrew, fiber wire, quite stiff one. So that was the first technique in 2002. So we went on, you can see how we did it. We did an additional drill here through the clavicle, pulled the suture through the clavicle and fixed it over a plate here. You can see the first X-ray here. It looked quite nicely. We were quite happy. And these are the first results. We did some cases, 17 cases, 40 years old, raw code 4 and 5. And 92% were excellent, had a good result. Constant score was nice. Some had an additional slap lesion. Then we went on. And why we did change? Because we had some pullouts, we had some suture failure, and we tried to use now this implant here. And we hope that we could use it with, reuse with a new implant to make it stronger. So this is the newer one, the tightrope. At that time, in 2006, I used this for the syndesmosis on the ankle joint. And I said, why not? We should use it also here. We should use it in the shoulder. Why not? And it looked nicely with a small titanium plate here. We could pull it through. We had a drill here, a drill hole of 4 millimeters, just that we could pull out the two titanium plates through the clavicle and through the coracoid underneath, flip it underneath under endoscopic control and pull it down. And that was not so bad. It was anatomical, it was stable, still minimal invasive. We also did some biomechanical testing with a tightrope. We measured the vertical static force and the dynamical vertical force until failure. You can see just some slides here, how we used it here. So we were quite happy, especially for the anterior-posterior movement. It was quite nice. It gives us more possibility to fix it. And we were closer to anatomy. So you remember we have 2 ligaments, you have a trapezium and a conoidium. They are like ACL, PCL in the knee joint, and they have different function. because the AC joint has a lot of motion, vertical and horizontal translation, but also rotation. And this is really important. So when we try to stabilize, we should think about the AC ligaments here, the trapezium ligament and the fascia. For the vertical, here for the vertical mainly, the conoideum and the fascia. So both ligaments have a special value, special function in the AC joint. We also measure the distance on the insertion side of the coracoid, and we learned that when you drill in front of the coracoid, this is just the coracoid, the insertion of trapezium, conoideum here. So if you drill somewhere here, you will have some failures because the distance in most cases is just 5 millimeters, the diameter. Here on the base of the coracoid is 9 millimeters. So you're on the safe side if you just do it here at the base where we have our anatomical insertion site. So not on the highest point of the coracoid, so just at the base. It's also published in HSM. And now to make it easier, there is now some measurement when you can measure from the AC joint to the insertion site, 2.5 for trapezium, 4.5 for conoideum, and then you're on the safe side. So you can just measure it. You don't have to open it, everything, and then you can drill. And another interesting factor was when we did the first cases, we learned that a lot of cases, 25%, had additional lesions inside of the joint. So when we use a scope and arthroscopy, in addition to the reconstruction, in 15%, we had a slab lesion. We could find some fractures. You could find some rotator cuff tears. So another really good indication to do an arthroscopy, because we have additional concomitant lesions, not only the AC joint itself. These were our first 5 years results. Now, arthroscopic assisted two-bundle anatomical reduction of acute AC joint separation, 5 years, HSM published in 2013. We had 23 cases. And again, the results were really nice. At that time, we didn't touch the AC joint. We had some undercorrection, some overcorrection. Even after 5 years, we hadn't seen some displacement in comparison with 2 years results. So we were quite happy with the first results. But now we wanted to go on. And why we did change? Because we had two tunnels on the coracoid side. The placement was not so easy, crucial for outcome and risk for failure. That's why we want to address the horizontal stability with suture cerclage. We had now technically the fiber tape. We had duck bones for fixation, not only just simple titanium plates. So we had additional technical help to fix the AC joint. And that was the next technique we used. Dog bones here, as you can see here on the clavicle and on the coracoid. That's now published in arthroscopy as a technical note. It's an arthroscopic assisted treatment for acute dislocation of the AC joint. And in these cases, with this key wire here, just during the surgery, here an additional cerclage around the clavicle and the acromion to reduce the horizontal instability. That's for acute case. If it's less than 3 weeks, we don't need a graft. If it's more than 3 weeks, but that's just a consensus, it's no scientific value, it's no evidence, we use an additional biological graft like a gracilis to give, we need some biological tissue because otherwise it will not stay for a long time. This is the technique, still similar technique we are using today. We have some passport cannula here from Artrex, and this is a guide here underneath the coracoid. Then we have a drill with an insole inside. So we can, on this arthroscopic control, we can place the first drill just at the base. So we see 1 and 2, and then an and the next spur is going over the first drill. You can use this. The newest one is 2.4, 2.8 or 3 millimeters. So it's wonderful. We don't have really big holes anymore, as you can see here. And then we are using here a lasso, an ethanol lasso underneath, and under arthroscopic control, you can just pull out the lasso and you go outside, and then from outside you go back in, and you can pull back the plate, any plate you want to use. Here's a Duckboard plate. That makes it easier. You don't have to go use the small plate going through both tunnels. So we have small tunnels, we have bigger plate here. So it was really a really good evolution now with this technique. As you can see here, 2 dog bones underneath the coracoid. You can place it correctly. One just at the base of the coracoid for the conoid ligament, and the second one for the trapezium is a little bit more anterior. And when you pull it in with the nitinol wire and another 2 tapes, fiber tapes, so at the end they are just parallel here, as you can see here. Now the second one is coming in, and at the end it's just parallel. So you can place it easily if you prepare in the beginning the surface of the coracoid. This is the final view. And on the clavicle, again, we have the 2 tunnels. We have 2 tapes here, 2 fiber tapes here, and then the two dog bones here. They just can use to fix the fiber tapes above the clavicle. And in addition, as I told you, we are using the gracilis. So one tunnel is a little bit bigger than the first one. It's 4 millimeter now. Then we can use the gracilis through one tunnel, mostly the conoid, and the gracilis can go around the coracoid and the clavicle, and we fix it above. So what about the horizontal stability? So if we have, now we go look a little bit more in details of the biomechanical problem. Here, when we have just one fixation, coracoclavicle, a central CC fixation, it doesn't restore the horizontal stability. And just to improve our techniques, we learned and we said, okay, we need something in addition for the AC joint. And in this study from Tim Sayer from our group, published in KSTA, we could show that an additional cerclage, an AC cerclage, could really improve the horizontal stability dramatically, significantly, much more. This is the native, the CC, and here the CC and the AC cerclage together, and it could really improve massively. That's why we are using it now in almost all cases. Now here you see the numbers. That's quite interesting. We had 12 human shoulders. The horizontal displacement in the normal shoulder is 10 millimeters. Even after 5,000 cycles, it's a little bit more. If we dissect the AC ligament, it's 40 millimeters. If we try to reconstruct the CC alone, we can just reduce it a little bit by 30 millimeters. But if we also fix the AC joint, we almost have the same value like normal, like the native. So we are going down to 10 millimeters, even with a little bit of 3 millimeters after 5,000 cycles. But so if you use both, you're on the safe side. It's much better. What about the figure of 8 cerclage? How should we do it? Now the next step was, how should we do it now? Should we do it in a box or in a, like here? Now you can see it, how we can do it here. We are a lot better. Here is a cerclage like, here through the coracoid, through the clavicle, crossing the sutures here, gives you much more fixation. So an additional cerclage provides much better. It has a lot of biomechanical advantages for the horizontal, but also for rotation stability. And you can add also an additional graft, as I show you here. The graft is going around, and you can use the graft just here. And you can see here the numbers here, if you do it alone or if you do it together. Now the next step. If you drill through the acromion, you get some fracture risk, and we thought we should go more, we should improve our technique, and we'll work for an internal brace for the AC joint. I try to show it now. And one concern we had at that time is maybe we have too much pressure in the AC joint. Remember, in the first group, after 5 years, after 2 years, we didn't have some osteoarthritis. We had just a stable situation. And we didn't touch at that time the AC joint. We just removed the disc between, but we don't have really some osteoarthritis. But when we fix now the AC joint with a cerclage, maybe we have too much pressure. So we used in this study a sensor glued. We glued it to the acromion. We measured the pressure, pre and post cycling loading, normal, -3 and +3 millimeter position. And there was no significant pressure in the native and when we reconstructed the CC ligament. So around 3 millimeter, it doesn't result in an increased pressure. So again, you can use it. You are on the safe side, no problem at all. Now, coming now to the classification system, because the biggest problem is the type 3. Type 3, now we say there's a type 3A and a type 3B. Type 3B means we have horizontal instability. We can start with a conservative treatment. If it's still unstable and painful after 3 weeks, then we can use an addition, then we can go to the surgery, we can do a surgery. If it's not unstable after 3 weeks, it's for us a type 3A, we can do the conservative treatment. And that's what we publish now as a consensus in the ISOCOS Upper Extremity Committee, in the Shoulder Committee of ISOCOS. Now we see the group here work together, and Knut Beitzel published it in arthroscopy. Sorry. Okay. What do we know about the functional anatomy of AC joint? See, the CC ligaments prevents superior translation of the clavicle. We already spoke about. There's different parts of the CC ligaments. It's the intact, the capsule dissected, and now looking for the horizontal instability. AC joint capsule now itself and the ligaments, they are the primary restraints for anterior and posterior translation. If you transect the capsule, it could clearly show how important the capsule is. So they are also much more important now for rotation stability. The center of rotation moves anteriorly if the AC ligaments are cut. So especially the most important part of the capsule is in the posterior part of the joint. So when we try to reconstruct, keep the posterior capsule, try to reconstruct the posterior part of the capsule. Now you see now a horse riding, and that's why our shoulder girdle is completely different to horses. In horses, the scapula has a pendulum effect, and they have a lot of muscle suspension. We do not have that. That's why we need a strong clavicle here, and we need a strong fixation on between the sternum and the clavicle, the AC joint, and we need a strong fixation here on the AC joint, because both joints, they contribute to the physiological motion of the scapula. Look at this. So the strut function of the clavicle allows forceful motion in 3D direction. Now look at the scapula. That's not really normal. See what happened here? So here, that's a normal one. And here, AC joint instability on the left side. And he has really problem to keep the scapula in position. It's not the same like horses. He really has problem. And that's why we know that the clavicle is so important. Okay, now we go a little bit more surgical pearls and tips. Again, try do not resect the lateral clavicle because you shorten the clavicle, and you have seen in our cadaver model, if you resect the clavicle 5 millimeters, only 5 millimeters, just the size of a shaver, you reduce the stability quite a bit. If it's 10 millimeters or complete, it's just above. So try to keep the clavicle. You can reduce the caps, you can resect the disc if it's damaged, but keep the bone structure. So respect the anatomy, second point. Start here from the AC joint, 25 millimeters, 45 millimeters. Here are our drill holes. Drill holes for conoidium and trapezium. Conoidium is a straight one, more posterior. Trapezium is more anterior. When you look from the front, is the coracoid. So here you can place your drill holes when you have your guide. And the bone density and the stability, so the bone density is much more on the lateral side. Again, if you drill it here, you can keep your holes and you're still on the safe side. So
Insert
again,
the AC guide through a low anterior portal.
yeah, you see the anterior portal here.
Drill through the clavicle and coracoid.
That's the first drill.
Remove the
insole.
trocar and retrieve the nitinol wire from the cannulated drill.
Then we catch the nitinol wire, pull it through lateral. Then you reduce the clavicle.
Shuttle the fiber tapes retrograde and seat the dog bone button against the coracoid.
The duckboard
Attach a dog bone button to the sutures exiting the clavicle.
Now you can reduce
the clavicle and tie fiber tapes over the button. Cut.
Again, our own video. Now I cut it a little bit that it doesn't need so much time. So working portal is very important because you have to go several times in and out. That's just medial of the biceps tendon, an additional portal here, suta supraspinatus. You can clean the undersurface of the coracoid, then a small incision around the AC joint. And before we start drilling for the clavicle, we just do the drilling of the lateral clavicle and the AC joint, and we shuttle the fiber tape. We don't fix it completely, but we have now this in place. And now we can use it here. Here's our drill guide. You can do an X-ray, see if everything is perfect. And then again, underneath, one dog bone and the second dog bone above. That's the final fixation. And this is the final X-ray, postoperative X-ray. So just in a short video. And again, some steps again, you can see it again. So use enough time to clean everything here because we need some good view from the side. We are just in the line of the subscar. We prepared quite nicely. And then that's so important that you do this before you do, because the clavicle is higher. So it's easier to drill from anterior to posterior, pull your key wire, and you drill just through the acromion, through the clavicle. Again, use the nitinol wire. It's always the same instruments. You can use a link or just pull the fiber tapes through, and then you cross it like here and fix it as I showed you before. And then when you have that, then you can use the drill guide here, one from the working portal here, and you drill the both tunnels for both. And then at the end, pay attention to fascia, close it nicely here, close it because the fascia is important also for the horizontal stability. Here's just a case now, a 50-year-old male, mountain guide. He had a trauma when he was skiing, type 4. Conservative treatment was started. And then after 8 months, he came again with pain. We did some physical therapy and focused on the scapular setting. Then after 1 month, we said, now we can go for surgery. And we fixed it with gracilis, dog bone fixation, and we did the tenodesis of the biceps then because he had instability of the biceps, and then insertion at the so-called degenerative slab lesion. And that's the some other pictures from this guy now. This guide is in this next guide here. Hook blade in the beginning was not stable. Removal of the blade, a zero reconstruction, still unstable. Otherwise, it's still, in this case, it's still a good technique. And here in this case, we used the tendon as an interposition between the clavicle and the acromion, just to reduce the pressure, reduce pain in between. And this is 6 months after surgery, and you can see how he can elevate his arm quite nicely. The future, we are working on a knotless system, so we can avoid the knot here on the surface of the clavicle. That's the system here. It's like a Chinese finger trap system. You see the first cases here. We are still working on it. It's not the final system. These are the first 4 cases. It looks quite nicely, so we don't have here some knots, because some patients they are complaining about the knots here above the clavicle, especially on high-level athletes. So it gives you more possibility. So finally, should we really operate on AC joint instability at all? This is our current concept, as I told you. Type 1 and 2 should be treated non-operatively. Type 3, you can wait. There is fair evidence favors initial non-operative treatment. This is the algorithm we published with ISOCOS. Rockwood 3, the biggest problem, if they still have pain and the scapular dyskinesia, and then you do a cross-body test, an adduction view, Basmania, Alexander X-ray, is the clavicle overriding, then you opt for surgical treatment. If not, no overriding, you still can continue to conservative treatment, non-operative treatment. So that's type A, no pain at all, you can continue conservative treatment. If they really have a crossing of the clavicle above the acromion, now this is perfect indication for fixation. You cannot treat it conservatively. As you see here, the scapula is swinging around, the clavicle is really overriding. Postoperative, a little bit restrictive because it should heal anyway, around 6 weeks, some kind of restriction, 30 degree, 45 degree, 60 degree, something like that. So the first 6 weeks, it's a good idea to little bit restrictive, even in special patients, because they don't have pain, they do too much. So remember, the results are quite good. These are our first 5 years result. Now, in a second study, we did return to activity after anatomical reconstruction. All patients went back to sports. No significant change in activity level and participation in overhead or contact sports observed. Published in BMC, open access. So with this technique, you can get quite nicely really good results. The biomechanical comparison of arthroscopic repair here, another 2 studies, using this internal bracing for AC joint box technique gives you again good results. The biomechanical studies are here. And coming back to our first case, we used again the same technique, but with a bigger plate here, another plate here, more on the base of the concrete to bring her back to her professional level as a snowboarder. And it's still possible if you use the same technique. So what we learned now, the AC joint is really important for proper 3D motion of the scapula. There's still low level of evidence, a lot of consensus, no gold standard, respect really the scapulothoracic function. If not, wait, you can start treating them with physical therapy. Think about anatomy. Internal bracing will help, and it's effective. It's proven now. I recommend a biological graft if you are not really, if you go after 2 or 3 weeks. I think it's a good idea to give him the tissue for healing. So thank you very much. I hope I could show you our idea, our philosophy, our strategy, and I'm happy to answer your questions. Thank you.
Thank you, Dr. Imhoff. So if you can unshare the screen and we can then have some questions coming in.
Thank you very much. That was an excellent talk and a great contribution all the way from 2002 for this particular type of injury. Great. Thanks. IPS questions?
Yeah. So first question here is Andreas. Do you usually use just a single grassless graft to reconstruct in an older injury, the coracoclavicular ligament, or sometimes you use 2 grafts as well?
No, because we still need a stable fixation. That's why I use in most cases 2 systems, 2 tightrope, dog bone, fiber tape system for the 2 ligaments to give them enough stability, especially the contact athlete, overhead athlete. And then in addition, I use just one tendon, normally the gracilis tendon, going through the tunnel, through the bone for healing. And then in addition, just around the clavicle, in addition, I give you some additional tissue. But the gracilis tendon is normally 28 centimeters long. You also can use part of the gracilis for the AC joint in addition. But that's not so important. If you have enough fascia around, you can use the fascia for closing and some tissue around this AC joint. So one tendon is really enough.
Okay, sir. I have a question. IPS.
Yeah, Samantha.
Yeah, the thing is that when you go with the, suppose with the chronic, your AC joints, most of the time, because we get a lot of many chronic cases, do you Prof suggest that when you do your lateral and clavicle excision or the Mumford, then you go ahead with your tendon around the AC joint, or because some of the papers are coming like that, or what's your opinion on that?
Yeah, never do a Mumford procedure. Remember that you reduce the clavicle and you reduce the strut function, and it's very difficult for people to stabilize the shoulder girdle. Maybe they don't have pain, but they cannot really use the arm. So we see a lot of bad cases now, difficult to treat because they're unstable. And if they bring the arm to the front like this, they get pain again because clavicle will touch the abdomen. So in chronic cases, I agree with you, resect the damaged disc in between, but try to use as much tissue as you have around the joint, just to close the joint here from both sides, anterior, posterior. And even in these cases now, I learned, what I learned in the last years, I try to put something in between, just to avoid direct contact bone to bone.
Great.
Okay. So
Doctor,
basically you were just giving some sort of tissue on the top of the clavicle and AC joint just to stabilize in the chronic cases. Am I correct?
Yes, correct.
Dr. Maheshwari, Shashank, any questions?
Yeah. So can I ask one?
Please,
Yeah,
do,
sure.
yes.
Okay.
Yes, sir.
So, Professor, what is the role of excising the lateral end of the clavicle, even in a primary case? Eventually, our worry is that when the bones will contact each other, they will cause pain.
Correct.
So in primary, of course, in secondary, what is the harm or what is the situation about excising the lateral end of the clavicle about 5 millimeter to be very sure that in future, the bone ends will not get in contact with each other. And that's a security that there may be no pain.
Yeah, as long as these joints are stable, if you do in a chronic AC joint arthritis, no instability, then you can resect a little bit as a pyramid like this. You keep the posterior capsule, you keep the superior capsule, then you're on the safe side. But if you resect everything, like Mumford, that's the worst case you can do. You get an unstable, painful joint. So try to avoid it. You really can resect a little bit of the lateral clavicle, like I said, as a pyramid from inferior arthroscopically, but still keep the stability, keep the capsule superior and posterior. These are the most important part.
Now, another question I want to ask is, which is very usual. You know, orthopedics is a very functional specialty. I mean, you do things depending on the need of the person. So, Europe, for example, is a very sporty society. And I am in Delhi and I see patients who are mostly techies. They're sitting on the computer all day, hardly play any sports, and they fall from a two-wheeler scooter, for example, and they have this bump there. Now, I don't know what is their need, and I ask them, do you play any sports? I don't play any sports. So what is going to bother them if I leave them as it is and they accept the bump? They ask me, what is going to happen if I leave it as it is? I don't play any sports anyway.
Yeah. I don't resect the superior bump. I just leave it. Just leave it.
So in such a person with low activity who is not into sports, do you think you will have a tendency to leave them alone, and would they be suffering, say, 10, 20 years down the line?
No, it's not the bump. Sorry, it's not the bump. You can do it. You can resect it arthroscopically, as I said before. But when you resect the bump above, then you have to add something for stability at the end. That's why I leave the bump.
So my question is, would you treat? My question is, would you treat such a patient, say type 3, 4, 5, when they come fresh to you?
Yes.
That means
Correct.
they're fresh injury, but they're low activity, they don't play any sports, and they don't mind the bump.
Oh, okay. Now I understand. No, I agree with you. If they don't need really their shoulder, you can leave it. And that's why I said, if you discuss it with the patient, you still can wait 3 weeks, 4 weeks. You still can do it. And you see what they are doing, if they are going well or not. You still can do it after 3 or 4 weeks.
Mm-hmm.
And then they learn. If they use the arm and they see if they keep my arm like this, it doesn't work, they have pain, then you still can do it.
And for you, it will be 3 weeks or the 4 weeks as a cutoff period to make that assessment?
Yes, because in the first 3 weeks, you still have enough tissue. So after 3 weeks, you can do it. If it's longer, then you need an additional tissue. You need a tendon. And a lot of people, they don't like that you go to their knee joint and pull some tendon. They don't like that. So I always tell them 3 weeks, and then you have to decide now or not.
Mm-hmm. Thank you.
Jaya, Shashank, any questions before I kind of fire a few?
I just want to, he mentioned, can I?
Yeah, sure.
Please.
Professor Imhoff, you mentioned in the passing that you're trying to put something in between in case you resect clavicle. What are the tissues you're trying to put in between the acromion and clavicle in case you need to resect it?
Yeah, I try to use the capsule just around, maybe the anterior capsule, because the anterior capsule is not so important. You can just pull this capsule to the posterior side with some sutures, fix it on the posterior capsule from anterior to posterior. Or what I also did in really chronic cases, very painful cases, they already had several times resection, the clavicle was quite short. I used an additional autograft, some dermal tissue, something like that, and I had to wrap around the clavicle because it was so painful. That's another option. You can use an additional tissue like you have, so tissue bank or whatever you want.
Okay. Thank you. Yeah.
Professor Imhoff, do you use sometimes the soft tissue graft to restore the as well? So like an encirclage, do you use a soft tissue graft also sometimes around it?
Yes, but not alone. It's not stable enough. I don't trust it. So in addition, yes. And that's why I use one drill, the 4 millimeter drill with fiber tape together with a tendon. So I have both at the same time.
Yeah. Okay. Yeah, Jay Prasad, you had a question?
And this is a question regarding the...
The volume is low, Jay Prasad, if you can.
Yeah. Now it's okay?
Yeah, that's better.
Yeah. So Andreas, this is regarding the type 2B in high-end athletes where cross-body adduction is negative. In spite of that, do you opt for the conservative treatment or operate? In
Oh.
suppose it like a boxers where the axial load is needed, in that patient, do you operate on that patient?
Yeah, I personally are going more in direction of surgery because it's not a big surgery. It's easy to perform, give you give you perfect results. You can predict on that. But you always have patients, they are not so sure if they need it or not, maybe not, then you still can wait. But if you have an athlete who needs his shoulder boxing or whatever overhead, I always do it.
So another thing is the figure of weight with tape you are doing with the drilling the clavicle and the acromion. So I modified little bit. I made a bioraptor, 4 bioraptors, 2 on the clavicle end and 2 on the acromion end, made a tape like knotless anchors. So in oblique fashion, so that bioraptor drill bit is very small and it won't go in a deep. So in oblique way, I'm doing a 3-4 cases. It is giving good results.
Yeah, perfect. But it's a little bit expensive.
Yeah, correct.
Yeah,
Yes, I agree, exactly. And as you said, Prof, the 2.4 millimeter drill bit, which comes for the CC joint repair, you can use it for the internal brace or, or similar kind of suture.
Okay.
So you don't need any additional kind of leverage.
It's
So
perfect. Just the same drill. You can just use the same drill for all holes.
Absolutely. Now, if I have some questions, so now because we do an arthroscopic technique, would you do a pre-op MRI for all your AC joints? Is it required?
It's not required. No, it's not required.
Whereas the ones who do it open, perhaps there is a role of MRI because as you showed in your study, there's a 25 to 40% incidence of associated injuries, especially in there. Great.
Because you you use your scope, you go inside, you see it. Sometimes, and most patients, they ask for MRI because everybody wants an MRI today. So why not? But really, to be honest, you don't need it really. You can clinically, if there is a rotator cuff tear or fracture, something like that. And you go inside, you use your scope, you see it, you still can do it. So to be honest, you don't need it really, but if they have it, it's nice.
Great. The other thing is now that we have a dock button, which is a much stronger implant in terms of resisting the forces of the AC joint, is it safe to say that just a one tunnel technique will do the job and you don't really need 2 tunnels? Because there's a risk of coracoid fracture, especially for those who are not really doing this day in and day out.
Yeah. Yeah, there are a lot of risk in the world, I know. If you drill not correctly, you shouldn't do it.
So because in your talks, you showed.
Since we have these small drills, it makes it so much easier. In the beginning, I remember when some companies had some systems with 6 millimeters drill, that was really worse. And we had a lot of complications, coracoid fractures, clavicle fractures, whatever. So really use small tunnels.
Sure. My question actually was that you showed 2 examples where in one you showed 2 dog buttons and in another example you just showed 1. So in the interest of the wider audience, is there any cases like a higher grade AC joint injury you will use 2 dog button versus a low grade like a 3B or a 4?
Well, if I have a patient who is boxing or doing a lot of contact sports like ice hockey players, they don't have pain. They just get in contact until they die. So that's why I use 2 systems to be on the safe side. Okay. But biomechanically, 1 is okay. You need only 1. But some people, they don't believe what you say. They just start with their sports again. They don't wait. So that's why I do talk.
Shashank has a question. Shashank.
Yeah, share, sorry to I have a question which is related to your previous question. Professor Imhoff, it is very interesting that you said that you see about 30 to 40% associated injuries in the MRI. How many times those injuries were significant enough to be intervened? Like what additional procedures you did, even if you found those injuries, like slap 1 or 2 injuries, slap 1 injuries, or other partial tear of the cuff, all or minor labral tears, how many times, what percentage of these lesions actually needed your another intervention in addition to AC joint repair or reconstruction?
It's a very good question. So 15% had a problem with the biceps insertion, slab lesions. We treat them. We don't fix the slab. We cut the biceps nowadays, and we fix the biceps subpectoral. Partial tears of rotator cuff we don't treat. And sometimes we had some small fractures or fractal lines, tubercular myas, major tubercle, we don't treat it. But it's especially the biceps tendon, because otherwise they have pain when they try to use the arm again. I think you should treat these.
Ranjit has a
Thank you.
question.
Yeah, Professor Imhoff, it was an excellent talk. In fact, I had started my arthroscopy stabilization of AC joint seeing your videos only. Sir, my question is, when you are reducing the AC joint, are you over reducing a little bit, anticipating that there will be or you just reduce line to line, and if at all any loss of reduction, you accept that?
Yeah, also very good questions, because the fiber tape is so strong. It's glass fiber, it's Kevlar, so it will not change the position. You know, there's a discussion, but when you have something like that, you don't need some overcorrection. Because what does it mean? The clavicle is deeper, you reduce the suprachromal space. I wouldn't do it. I wouldn't do it. If everything is correct and you have a good stability and the knots are perfect and the titanium plates are perfect, because we haven't seen really displacement of the titanium plate over the years, maybe in the first several weeks, but then it is on the same position. So I think there's no reason to over reduce it.
Can I?
Yeah, Dr. Maheshwari.
Yeah, so I have often wondered that you make a hole in the coracoid and you make two or one, whatever hole in the clavicle, and you tighten them. Now, unless these 2 points are very, very isometric, they would not produce a 100% reduction of the AC joint. How can you detect in a particular patient what is the location of those 2 points, that when you tighten them, you're going to get a good reduction of the AC joint?
No, as I showed you, the anatomical part, you have to drill correctly, place the tunnel on the coracoid really at the base where the conoid ligament is, and then you're really isometric. It's no question. And the
How about the clavicle?
The clavicle again, 2.5 centimeters from the AC joint and 4.5 for the second tunnel, again from the AC joint. These are really isometric. The only problem we have, the little bit of rotation in the clavicle, and that's why fiber tape are much better than a Bosworth screw or fixation by key wire or something like that. Oh, it's really isometric.
Do you think one should reduce the AC joint and put 2 temporary K wires and
Yes.
then tighten it to make it sure that you're not overdoing it?
That's, maybe you haven't seen it on one slide. That's why I start with drilling the tunnels for the AC joint, and then I use an additional key wire for the AC joint, keep it stable, especially in the type 5, or when you have a lot of dislocation. It makes it easier because then it's perfect.
Prof,
But
you showed
it's not so easy, because then you have an additional key wire in your bone and you still should drill through the clavicle. So think about that before you drill. Otherwise you get a conflict.
Now, Prof, as Dr. Maheshwari mentioned earlier, that most of our patients who are not sporty, we treat them non-operatively. Now, if there is a grade 3B or a grade 5, which we have treated non-operatively, how closely do we need to follow them to make sure that if they develop scapular dyskinesia or some sort of alteration, do we need to offer them surgery?
Yeah, I always see them after 6 weeks. The first visit is 3 weeks, the second is 6 weeks, and then you can leave them. They can come back if they have really a problem.
Okay. And
But
what
after 6 weeks, you see it, because that's a time where the physical therapy can work. And if you don't see an improvement after 6 weeks, it doesn't make sense to wait longer.
Okay, great. Now, there is a lot of confusion regarding what exactly is the timing when you call an injury chronic. So when would you decide that you would augment it with a biological graft versus when you will just do a CC joint repair and an AC joint repair?
Yeah, that's not a clear definition. It's just a consensus that we see, that we say now about 3 weeks. That's just this consensus. So we have seen after 4 weeks, 5 weeks, there's not a lot of tissue between clavicle and coracoid. So you need something in addition, otherwise it will never heal. In the first group, I have seen some calcification between the coracoid and the clavicle. So just along the fiber tape, we have seen some calcification. So that means that the bone pieces of the drilling will also help some healing, have some potential, but bone healing potential. That also may help. That's why I think so around 2-3 weeks somewhere you should add something.
Okay, great. Any further questions from the floor?
I'm in an already painful AC joint due to maybe a low grade arthritis or and it dislocates after. So do you do something differently, or would it be treated like a normal acute AC dislocation?
It's the worst this is the worst case you can imagine, pain and instability at the same time.
Yeah.
So, especially these cases, I send them to the physical therapist, try to reduce the scapulothoracic motion, and just to learn the patient, if he can understand what he has, what is his problem, maybe also have a look at the back and the spine. Maybe they have some cervical problems also, because just fix them, you will not reduce the pain. So they have a stable AC joint, but still pain. So be really careful. That's the worst case. I agree completely. That's very difficult.
So
Yeah, Professor. Hello. Okay.
May I?
Yes.
Is IPS saying something?
No, that's okay, Shashank. You and Jayaprasad have one question each, and then we can conclude.
Okay. Professor Imhoff, in a clinical scenario, in acute injury, not like about 2 weeks old or less than 3 weeks old, or how do you conclusively rule out posterior instability? I mean, I don't see any X-rays. I see CT scans have a very fair degree of problems there. It reduces itself. How do you clinically, or how do you rule out posterior instability where you are doubtful that it might be, it might not be?
Yeah, there's a typical X-ray direction. It's a so-called Alexander view or Basmanian view. Then you can see how the clavicle is riding over the acromion. It's just something under load, and then you can see it, not on the AP view and not on the CT scan or so. It's just a dynamic.
So while doing Alexander view, you are loading the joint or just cross body adduction? It's adduction view,
Yes.
right?
It's like this. So you can see it now. It's just you load it like this.
Yes.
Correct. Yes.
Yeah. Okay.
It's some kind
Thank you.
of loading.
Yeah, Jayaprasad, and then probably Ranjit also.
Yeah, I'm off. This is regarding the type 2 dislocations, where some patients will come with a pain. Have you operated on this patient? How you evaluated type 2 patients? And another question is, when we are operating in these patients, so which one we have to give importance in biomechanically? Is it a rotational stability we have to see, or anterior posterior, or a horizontal? Which one will we have to see and fix it in AC area? These are two questions.
Yeah. You know, type 2 means that you still have an intact capsule, you have still intact ligaments. I don't treat them. That's something what I think you can make it worse. let them do some physical therapy, that's okay. If they have osteoarthritis, what we discussed earlier, that's completely different. Then you can do surgery. Then you do a resection, arthroscopic resection of the C joint, but not when they're coming with a type 2. No, you make it worse if you try to do it.
Second question is biomechanically, which is a very important thing when we are stabilizing the AC joint.
It's
Is
both.
it a rotation we have to see, or anterior posterior stability, or the superior inferior stability? Which one we have to address, really address?
Yeah, it's what we really learned is the horizontal instability. This is a problem you cannot really reduce it actively. So keep an eye on the AC joint for the horizontal stability. That's my biomechanical, very important.
Yes,
But you
Professor,
cannot fix the AC joint alone. So that's why you need the CC also. You need both to really have a good stability.
Do you examine the patient after your AC joint and CC joint fixation, abduction, how the AC joint is moving, how it is, how much stability is there?
Yes, yes, that's for sure.
Perfect. I think Ranjit, last question, and then Shreyash can conclude.
Yeah, Professor Imhoff, what is your view on using clavicle hook plate? We know the acromion complications. Still, what do you suggest?
I have seen so many bad cases using a hook plate or because a lot of these cases, when you are really honest, if you took out the hook plate, the clavicle is going up. Why should the clavicle stay in the same position? You have no other possibility. It's not enough tissue. These patients, they are not going so bad because they have a little bit of instability, type 2. They're not really stable. That's the same when you use a post-first screw between coracoid clavicle. If you take it out, it goes up a little bit. So you use it to type 2. For some patients, it's not so bad, but it's not what we should do now because we have better techniques today.
thank you, Prof,
Thank you.
for an excellent talk. Being the secretary of the association is a great pride and honor that you have agreed. As my special thanks to Shreyas too for arranging this meeting. I think Shreyas will conclude now.
Right. On behalf of the Indian Arthroscopy Society and myself, Prof, I'm really grateful for you to taking time off and participating, and importantly, sharing us your years of experience. And you very clearly showed that unfortunately, non-operative treatment, especially for the grade 3B and above, does not work. And we really have to evaluate the patient's needs, the demands, and then address it merit by merit, and if required, operate them to ensure that they don't have any residual or functional deficits. So thank you very much once again. And as you mentioned in the beginning, really, it'll be a good opportunity for us to host you in person to have a social interaction at some point in the future. Till then, stay safe, and thank you very much once again for participating.
Thank you.
Thank you very much. Thank you.
Thank you.
Wonderful hearing you, sir. Thank you very much.
Thank you. Thank you.
I'm stopping the live stream.
Yeah, okay, perfect. Thank you very much, friends. Thank you, Shreyash.